Today's topic of discussion is breaking bad news. And as we were discussing that breaking bad news is probably one of the most difficult communication in the spectrum of healthcare communication, especially when the outcome is unanticipated, especially when you are not, you have no inkling that this case could turn into a difficult situation. But in any case, even simple diagnostic breaking bad news are also equally challenging. So if I may ask you, what do we mean by bad news? Sir, please unmute. Dr. Haq is, yeah, you are, yeah, please unmute once again and speak. Yeah.
Something tragic.
Okay, something tragic. That's a bad news, absolutely. What do others say? Mr. Hashim, what do you say?
Something unexpected.
Something unexpected, absolutely, absolutely. Dr. Ravi?
Either death or very profound morbidity, some, like disability, which.
Yeah, absolutely. Death or profound. Absolutely, I completely agree. And why profound? I'm sure you must have seen when you break this news to the patient's parents that your child is, hypermetropic or high myopic. Are they okay with that?
No.
No, absolutely no. I've seen, mothers literally starting to cry when they get to know that their child needs to wear specs, and especially when they see the thickness of the glass, if it is hypermetropic or if it is even high myopic, they are really shocked. They're really, really shocked that how will the child handle it's such a tender age. Even grown-ups cannot manage these specs. This child of 3 years, 4 years, how will he or she handle specs? It comes as a shock. So, what other kind of bad news can you think of? For example, in lab situation or in
Not reporting, ma'am.
sorry,
Reporting gets reports getting exchanged.
yeah, that is also a bad news. And also, in case if error has happened from our side, then
Exactly, ma'am. Errors, ma'am. HIV positive report being given to a negative person. That's the biggest. That is the biggest thing with what can happen.
Absolutely, absolutely. Dr. Kapoor, can you switch off your camera till you settle at one place? Because, yeah, thank you so much. Yeah, yeah. So if in case by mistake we have given a wrong report, a positive report to a patient who is HIV negative, it can come as a shock and the damage has actually begun already, has happened already. So to undo it becomes very challenging. Any other situation can you think of?
Ma'am, sometimes, we tell the patient, we find out that you have got diabetes or tuberculosis. The disease has so much stigma that they are crestfallen.
Absolutely, absolutely.
Although it's fully treatable.
Exactly. So things like diabetes, tuberculosis, hypertension, we all know that now people are, even, I mean, we have 1 in 4 almost, like, people suffering with diabetes and hypertension. But even when it is told to the person, it comes as a shock. It comes as a shock to them and it's not easy. So we'll do a small, practice session before we do the role play. So we are excluding me. I have 8 participants. So I'm going to break you in 3 rooms. So in each room, there will be 3 people, but in one, there will be only 2 people. So 3, 3, and 2. The idea is, I'll first show you the situation. The situation is that it's a young patient who's been diagnosed with CA pancreas. It's an early stage of CA pancreas. And you have confirmed with all the reports and everything. Now you need to go and inform the family and the patient about the diagnosis. So do 5 minutes practice session. So in this, I would request people who are doctors, let them not be the doctor. let people who are non-medical be the doctors to break the news. People who are doctors, preferably you be the patient or patient's family member. So, and in total, we will have 3 people in each group except one. So one doctor, one patient, and one patient's family member. And do 5 minutes of practice session. Family would behave the way they behave. Patient will definitely behave the way a patient would behave when you get to know that I have CA pancreas. And of course, the doctor who is supposed to break the news will do how do you really go about doing it. So I'll just show you this slide so that you know the case exactly. Give me a second to show this slide. Where are we? Yeah, this is the case. So your patient is a young man or woman who has been diagnosed with an early stage of CA pancreas. So you have to break the news to the patient and their family member. Okay, this is the case. So I'm going to now break you all in 3 breakout rooms. Yeah.
No, no. It's still live.
Very difficult for the doctor.
Yeah.
And for the patient, of course, but
No,
In
what
fact, the most
understand?
difficult patients are the doctors.
yes, yes, sir. Very true.
Like
Very true.
my own student diagnosed me with hypertension, and all this stuff. I gave him a mouthful first.
Can I
Yeah,
share one thing with you all?
yeah,
Yes,
yeah.
yes, sir.
Madam is listening, I think. When I was in medical student, during my first year, I was sick for a long time. And that time I was diagnosed as a cancer patient, unfortunately, a testicular cancer, and was given only 3 months time to live. Only 3 months. That after 3 months I will die. And I was given so expensive medicine at that time. And my father was having some issues that he every day after office, he went to the shops to buy medicine for me. And though after taking those medicine, I used to collapse for half an hour or 1 hour like this. My mother was afraid to come in front of me. That's because, her child will die very soon. So it was very pathetic for me, for my family at that time. After 3 months, when on the 19th day, 3 months, I was thinking tomorrow morning I may not see any of my family again. But unfortunately or luckily, I am still alive. What happens? Another 1 week gone, I'm still alive. What is going on? Then again, everything rechecked and found that the report was wrong. I didn't have any cancer. But it was a terrible 90 days for my family.
Definitely. Oh my.
But unfortunately, because of the medicine, my immunity was subsided. I have so many complications in my kidneys, in my liver, and that suffered me for a long 5 years. So when Madam giving me the topics, pancreatic cancer, I was thinking about that time.
And I was also wondering, sir, that you are, about the report you are saying.
Sir, what
But
happened?
Sir, ma'am?
I missed what you were saying. I missed the first part, what you were telling.
Sorry.
I missed the first part.
Oh, first part. For me, myself, but
Yes.
I was diagnosed with testicular cancer when I was in my medical school first year.
Mhm.
And the doctors given me 3 months time that after 3 months I will pass away.
Mm.
So the 3 months was horrible for us, for my family.
Mm.
Every day I was counting to death. On the 19th day, when the finished,
Mm.
on the next morning I wake up, still I'm alive. And I'm asking myself why I'm not passing away. Then again, all the report rechecked and found that it was a wrong report.
Mm.
And still I feel that pain. Sorry.
Extremely sorry, I lost my electricity and network both. Extremely sorry. Yeah, I think Dr. Haq was sharing some experience.
I thought you have gone for dinner.
No,
I thought Madam gone for dinner.
I did mention in the group that I lost connection. Dr.
yes.
Dr. Haq, you were saying, you were sharing some experience, I think, if you would like to. Yeah.
You gave us this topic that is a patient has head of carcinoma in head of the pancreas. So
Yeah.
Dr. Ravi was the doctor. I was the patient.
Yeah.
So I was sharing with them after discussion that I was diagnosed as a case of testicular cancer in my early medical life, and I got 3 months time to live in this world. So that 3 months was horrible for my family.
Mm.
My mother was not used to come in front of me. So after 3 months, I think Madam has again. So after 3 months, I am still alive. So I was thinking why I'm not dying. So at that time, this report again rechecked and found it was wrong.
Oh,
This happened. This is the thing.
we have a real life, experience.
Real life.
So, okay, so all of you had a chance to observe and participate in disclosure, the breaking bad news. Okay, so we will do a demo here. So I want people who did the practice, if anybody wants to volunteer to do a demo. Dr. Kapoor, will you be interested? Dr. Kapoor, are you there?
I'm there, ma'am. I'm having my dinner in the hotel.
Okay.
Sorry,
Okay.
don't mind it. I'm really missing it. I would have done it.
No, that's okay. Anybody else would be Dr. Farha, would you like to do? Or Dr. Ravi, I think, would you like to do?
Okay, ma'am. But ask my patient if he felt it was worthwhile, but then I
So
can
that's
do.
okay. See, we all are going to observe and learn from the role play. It's not to tell what you did right or wrong, because we want to learn from each other's experience. That's the whole idea. That's the whole idea. So it's all right. Nobody is perfect and we are still learning, no, because this is
Okay,
something that
ma'am.
we haven't learned formally. I completely understand. But
So I will.
before you do the role play, I would like to assign roles to everyone who are there in the group today. So there are a couple of things that I want you to observe. So we have Dr. Farhad, Rashmiji, Dr. Nair, three people, and Rehan and Dr. Kapoor. So Dr. Kapoor, will you be able to observe and report your observation, or you will just be quietly listening to what is happening? What is your...
I just want to quietly, ma'am. At the moment, quiet, ma'am.
Okay, it's all right. Yeah. So what I will say, Dr. Farha, can I ask you to focus or observe the interaction in terms of, you can note down what all you need to, observe. So I want you to observe the language part. What do you think he did effectively? What was something special you found in the language? Then paralanguage, tone of voice, compassion, care expressed in the tone of voice, speed of speaking, volume, all that. And then his body language. Did his body language connect with the patient? Did it show that empathy? Then empathy, if you could observe that. Then how did he build rapport with the patient? Although this patient is his old patient, because he has been coming to him and he has been sent for a number of investigations, and now it's on the, they've come to a conclusion that yes, you are a case of CA pancreas. But how did he build rapport before he broke the news? And then how did he begin the conversation? Because this is something not like regular conversation. So how did he begin it? I want you to observe these things. Okay.
Okay.
So, Dr. Nair, can I request you to observe the how did he respond to the emotions? How did he handle the emotions? Because I'm sure there will be some emotional reaction coming from the patient side. It could be anger, aggression, it could be anything, anything. Why did you not tell me earlier? Why did you get the test earlier? Why did you make me wait? It could be anything. So how did he manage the emotion? Then also, Mr. Hashim, can I request you to observe how did he manage his queries? I'm sure patient will have a lot of doubts and queries. What is the seriousness of the situation? How long will I live? Is there treatment available? Will I completely get cured? What is the duration of my, or how will this impact my quality of life? It could. How did he handle those questions? I would request you to observe that. And also, Rashmiji, I want you to observe, in case if the patient asks for some assurance, Dr. Saab, please tell me that I will be fine. Please tell me that everything will be okay. And I'm sure I'm in a safe hand, so I will be fine. And then how did he close the session? Did he close it? Whatever way. But so I would request all four of you to observe four different aspects, and I will be requesting you to unmute your device and speak for maybe a minute or so briefly and tell your salient observation. Is that okay? Huh?
Okay.
So I think we will all switch off our videos. Dr. Batani, you get 3 minutes time to do the role play. You can take 3 to 5 minutes time, but in case if I think I need to come in, then I will have my video on. Otherwise, I'll keep my video off till you finish your role, please. Yeah. So I'm going to switch off my video. Yeah. रश्मि जी आप भी वीडियो बंद कर दीजिए Yeah.
Okay, I'll start.
Yeah.
Yeah. Okay. Good evening, Mr. Huck. I have got all your, we have been doing all these tests for all these little problems that you have been facing. In fact, the last test which we had taken was the biopsy and the needle aspiration biopsy. I have got all the reports, and I would, just now sit with you and tell you that all this discomfort, this indigestion, all these problems you have been facing is because we have found a very little early involvement of your cancerous involvement of the head of your pancreas. It is extremely in the initial stages. Initially, we thought maybe it is, inflammatory, but the biopsy has shown that it is like this. It is nothing, I know that this is a little surprising news for you. But what I would like to tell you is that it is a very early stage. And we will have a stepwise treatment plan with which we hope that we can eventually get you to a as almost full recovery. Of course, we cannot be very sure about it, but the results in these cases are very good. The treatment may take a little longer than we had initially expected, and but we will be there with you at every stage of the throughout every stage of the treatment, the initial surgery, recovery from the surgery. Once the whole area has been sent for analysis, only then we will know further whether you need chemotherapy, whether you need radiation, and we will guide you through everything. I we have a very experienced, qualified team. We have dealt with such problems earlier with a good amount of success. I know that you are very young and you may be wondering that how this has happened, what this has happened, but sometimes there are just you are just people are prone to these kind of things. The good news is that we have caught it early, and with a good aggressive treatment, I'm quite sure that in good we will get you back to a very good quality of life. It might be a little bumpy road, but we will be there to cushion all these bumps. And at any time, any queries, we are just a phone call away. We are on WhatsApp, we are an email. Even if sometimes we are busy, we will get back to you at the earliest. So uh, please please think about this, talk with your family. If any of your other family members wish to discuss with us at any stage, please uh, tell them to not hesitate at all. It is important that we go into this as soon as possible.
Doctor, are you sure? Sure, the report is okay.
Yes, we have had the report. It is not that the fine needle aspiration which was done, we have sent it to 2 independent laboratories with the finest of pathologists who have looked at it, who have independently confirmed the diagnosis.
But sometimes report wrongs happen. You should check with other doctors, no?
Yeah, we have sent it to 2 very renowned centers for histopathology and to people who are specifically dealing with these kind of illnesses.
But is it very deadly, this pancreatic cancer?
Well, sir, I would say, any cancer should not be taken lightly. But because it is in the very early stage, it is not spread anywhere, it is very localized. So we hope to have it out of your body and then, treated with all the other necessary chemotherapy and radiation to prevent recurrences. I would definitely not trivialize the illness, but I would. Yes.
Is there any other test like beside this what is the FNAC? Is there any other test for reconfirming that I am actually having the disease?
See, sir,
Is there any other test?
see, one thing we have done the PET scan, which has shown that, that is the activity is localized over there. There is no spread anywhere at all in the body. It is very in a localized area. And basically the tissue has been examined. It has been seen under the cells have been seen under the microscope. It has been sent for immunohistochemistry, which has confirmed the diagnosis.
So surgery is required.
And I will share the photographs of the slides in the report with you. And in fact, we have also got if you would like another opinion, then we can always send these slides to any doctor of your choice if you would want another opinion. But I only beseech you that let us do it a little quickly so that we proceed with the treatment. But any other query, if you would like another opinion, we have got the slides. We are not going to just give a report. If we would want another opinion, we will share the slides with a concerned doctor. And we can always take another opinion. We are very open to that, so that you are assured about this. But we are very firm in our mind, beyond any doubt.
It will be cured 100%.
Well, sir, our treatment will be 100%. The experience we have had and the experience shared in the literature shows that the results are very good. We cannot tell you 100%, but we will do our very level best. And it is definitely worth going ahead with the treatment so that you get the best quality of life possible.
So treatment will be surgery or medicine or chemo?
Sir, initially it will be surgery because it is a very localized area which is involved. Then we will have a large block of tissue which will be thoroughly examined by the pathologist. Based on the staging of that, then we will decide whether chemotherapy is needed, radiotherapy is needed. So the initial step will be the surgical excision of the tumor, and then which will be subjected to examination to decide the proper staging.
So you do the operation or any other doctor?
We have a gastroenterological surgical team where there will be 2-3 of us who will be involved in the surgery.
I think it will be expensive, or no?
It is totally covered, sir, by your insurance, so you don't have to worry about that. So, that is I'm very happy that you have been, well insured. So the expenses will not be a problem. We will, as soon as you think about it, we will, from our end already, we will process the insurance. We will talk to the insurers and see that, everything is approved as the earliest.
So when you do the operation, you got that part of pancreas. Will you recheck it again for confirmation or?
Yes, most certainly, because then we have got the whole mass with us. It will be subjected to very detailed scrutiny. Although the fine needle aspiration shows these cells and confirms the staging, but like you were asking about what is to be done subsequently, is the surgery only enough? Maybe, but only once we get the results of the pathological specimen or the tumor which we removed. That.
Okay.
But it is definitely very localized, and I'm very hopeful that you should certainly come out of it very well. We will do our level best. If you're asking for a total assurance, I give you the assurance that our team will do our level best, and we have seen very good results. If we find that, let me tell you the worst side. that it is progressing or things do not, then we will, there is a protocol for that. There are things we can do. We are, prepared for most eventualities.
Okay.
But
So
all said and done, it is a cancer. So sometimes it might be a little beyond our control, but we will still try to rein it in and see that we can get you back to your normal routine and a good, long and healthy life.
okay, let's have some. So what I'll do, I'll bring my brother. You don't disclose it to my wife, okay? I'll bring my brother.
Certainly.
So you understand, no, it will be very difficult for her to know about these things. And I trust you that you are telling me the truth. And hopefully it will come right. But for me, it's very painful. No, understand? I think.
Yes, I can certainly understand. So
Let's
I
have
can
some.
imagine
So
that, if I was in your place, that to be told that I have such a problem. But what I would certainly request you is, okay, like we all have, now we've got this problem, rather than let us see what we can do to just get rid of it.
okay.
And we are all with you. You are not alone in this. You have put your trust in us and you have come to us, and it is our duty to see that we get you as back to good health.
Thank you, Dr. Ravi. Thank you. Thank you. Can I request everyone to come in?
It was wonderful from doctor's side, wonderful conversation and disclosing the news to the patient. I think most beautiful way of expressing or disclosing the such kind of bad news or such sad news. But patient was very, very strong after hearing the news. He was very strong, and he was fighting with doctor. He was judging the doctor in different way. But to be honest, it was really nice presentation from Dr. Ravi, from the side of Dr. Ravi. And we learned a lot from this conversation. It was model conversation, I think.
Thank you. Thank you, Dr. Ravi.
Please say the bad points.
We are not going to say the bad points, but first we will have the objective observation of people who were asked to give the observation. So I think to start with, I will request Dr. Farha to share her thoughts about the language, paralanguage, body language, empathy. I gave you a lot of responsibility to observe a lot of things. Yeah.
Yes, ma'am. It was the conversation was good, but I pointed out some points. First of all, when Dr. Ravi was going to disclose the matter, I think he could have asked if he is alone or he has someone with him.
We'll first talk about what he did effectively. Please bring this change in your way of conversation. Always start with positive. Always, even with your patient, their family member, your team members, your own family members, always start with positive. So bring this shift in your way of it, because then the person will become receptive to what you are saying. So this is called relationship-centered feedback.
Okay.
So tell what he did effectively. I think first start with that.
Yes.
In the second round, I will ask you, what do you think he could have done differently? Yes. Go ahead.
So Dr. Ravi, first of all, he brought everything to the patient about his reports. Then he explained about the condition and the diagnosis. He delivered in a very proper way to the patient. And he also allowed the patient to ask many questions that he wanted to know about the stage, about the financial costs, anything. And doctor also assured him in a very good way that we will try our level best to give the patient our best treatment. And he assured that he can also take other opinions, or he can also take help from others. But from the doctor's part, they will give their best. So he assured him in a very proper way.
What about the paralanguage part, tone of voice?
Yes, I think tone of voice was good, but I think a little he could do it a bit slowly.
Okay. What about body language part?
I think body language was okay. He was nodding, he was leaning forward, he was making eye contacts with the patient, and he was speaking very softly.
Okay. And could you see him building rapport with the patient?
Yes, he built his rapport with him.
Empathy part.
Yes, he was very empathetic.
He was
He
very
understood that the patient is feeling bad and patient is very anxious, and allowed him to express his feelings.
Absolutely. Yeah. So responding to emotions, I think Dr. Nair, I had requested you to observe. So if you could share your observation. Please unmute your device, Dr. Nair.
Ma'am, Dr. Haq as a patient, ma'am, when Dr. Ravi was breaking the news, he was visibly tensed up and distraught, like the way he took out his cap and then put it back. That was also a sign of that he's getting tensed up.
Anxious.
And he was doubtful about the results also. And that's the reason he asked me a number of times whether the doctor was convinced that he's diagnosed with the correct, and has come to the correct diagnosis. And he was disturbed and bit confused, which I felt was about the results. Might be that
we are focusing on how Dr. Ravi managed or responded to emotion.
And Dr. Ravi was absolutely point on 100% on target, ma'am, when he was correctly and in an appropriate manner he clarified all his doubts, which I felt was that that whatever doubts he had, Dr. Ravi was quite patient, and in a very perfect way he explained the patient the positive part, that it has been an early diagnosis and that they are ready even for rechecking of the slides also. That showed the confidence in Dr. Ravi also, that the diagnosis reached by him and his team is they are absolutely clear about the diagnosis. They were very clear. He was very clear about his diagnosis and treatment. So I think he was very convincing, and that's the reason the patient also got convinced in spite of his initial confusion and reluctance to apprehension, because he also mentioned that his wife should not be informed initially, so he was also concerned and equally disturbed, because he didn't want his wife also to be disturbed along with him. So so I think he had trust also, man. That was quite evident in Dr. Ravi. So I think that is there, man. That was my keen observation. Initially, he was disturbed, definitely, man. No doubt.
Yeah. Thank you for your observation. Yeah. So, Mr. Hashim, I had requested you to observe how does Dr. Ravi manage his patients' queries or patients' doubts and concerns. So, did he manage well? What you think he did with the different questions patients asked?
I already explained.
Yeah.
Dr. Ravi handled or deal the patient with patience, and he answered all the questions with in appropriate manner, and he was very anxious about the patient. He was empathized to the patient, and the way he disclosed the breaking news before breaking the news, he explained about the reports, the result of the reports, and as well as he assured the patient that it was in very early stage and the technology, treatment, everything within control. So if the patient start the treatment following the protocol of the treatment in early time, there are chances of recovery, high chance of recovery, and he used some language. It was surprising news for the patient, and he is not ready to hear this kind of news right at this moment. But he, as well as he assured the patient, it is still in control. And so I think,
so, Mr. Hashim, see again, from as long as things are going okay, when you assure, when you over assure, they are happy. The problem is there's a risk in over assurance.
Yeah.
It can misfire. We'll talk about it. We will talk about it.
Dr. Ravi used one thing. He will be 100% dedicated to the patient, but he cannot give 100% assurance to the patient, because from his side he will be 100% dedicated.
Yeah.
But he cannot give 100% assurance of recovery. He told it is very clearly.
Absolutely. Thank you. Thank you. Yeah, Rashmi ji, your observation on how did he close the session, and how did he ultimately end the conversation?
There were 2 points given, that patient asked for an assurance.
Yeah.
So I think that was covered by the earlier speakers.
Yeah.
So the patient, various aspects were covered, that whether the doctor was sure about it, whether the finances also, whether it would turn out to be expensive, that also was there. Then who is going to perform the surgery? A lot of confidence in the doctor that whether he would be, whether this stage is an advanced stage, whether it's deadly, and also his concern that please don't disclose this to my wife. So I think all this was role, and the doctor gave answers. And then next question was, how did he close the session? So according to me, he explained the pros and cons. He did not hide, the facts. So he explained that, and I think the closure was just apt, wishing him a long and healthy life. I think that's how he closed the session.
Thank you.
Thank you. It was
for very crisp observation. Thank you, Doctor. So, Dr. Ravi, if I may ask you, what do you think you did effectively in this role play? Can you, after hearing everybody's feedback, what do you think you did effectively in this role play?
Ma'am, in one word, if I would say, it is empathy. Because you do feel, you think, as a doctor also, you think from the patient's viewpoint. And the second thing was, as far as possible, to a layman, explain the technical aspects in a very simple way. And as you mentioned, ma'am, we cannot give false assurances.
Yeah, absolutely.
You gave us a very easy case, ma'am, in the sense that it was CA pancreas. But sometimes, like you said, in simple diseases, you land up with trouble where you give false, I would not say false assurance, but you yourself are sometimes overconfident, and you. So,
I have a request to Dr. Roki. If the cancer is not in the earlier stage, if it is in the end stage, then how he can disclose the news within few words, if he share with us. If the cancer is in end stage.
You want me to say something? Well, sir, we have been going through various stages of your treatment of your condition, and we have not found the very optimum response. And the chemotherapy is also taking its toll, but it is at least helping you to, remain in somewhat good health. But
it's difficult.
You'll have to give me a minute. I'm really.
I think it's okay. We'll not put you on spot because it's difficult to all of us are done.
I would have to think about this really before.
But Mr. Hashim, if in case if the prognosis is poor, I think we have to be straightforward but sensitive when we are breaking the news.
Sensitive.
I'll be sharing a protocol just now after the discussion.
Okay.
So you will get to see how we have to do it, and then maybe in between I'll give you a short demo to help you understand how you go about. So in case if this is the case, and I know this case, I mean, even if we haven't begun with the chemotherapy or radiotherapy, but I've got the report and it is spread all over. We know it is metastasized all across. So, and we have to break the news to the patient and the family. Again, we have to be sensitive but straightforward, because we don't want to give them a wrong information or a wrong hope. So we of course we need to, again, here building rapport, opening the dialogue, making them comfortable, asking them. I'll be sharing that in a minute. Give me a minute. Thing. So Dr. Haq, if I may ask you, how was it to be in the patient's chair, especially like when Dr. Ravi broke the news? As a patient, how did you feel or experience?
Dr. Ravi was very good in assuring the patient the treatment is not that much complicated.
Yeah.
And he will take care of everything. And he was very confident regarding the diagnosis. And he assured the patient in the very polite and humbly that the patient, I think, would not get that much distressed. And I think he did his job very well.
Yeah, I think the partnering was very well done, because he could make the patient feel that I am with you in it, and we will do our best to provide you all possible support and care. That part was really, really done well. So, Dr. Ravi, if I may ask you, given a chance, is there anything that you would like to do it differently?
Ma'am, one thing which actually Dr. Farah was beginning to mention, that there should be someone else with the patient, because sometimes the patient is so much in shock that are they listening to what you are saying? Sometimes they are so numb.
Yeah.
So that is very important, to have some responsible family member along with it.
So maybe even before we start speaking,
we should make
a couple of questions, like, for example, is there anybody with you? Have you come with somebody? So he will say, yes, I have my brother waiting outside. So do you want, and again, seeking permission, do you want him to be called in when I'm discussing? Because see, if we look at the situation from the legal point of view, we have to seek patient's permission to allow the family member to overhear our conversation. But practically in India, I think family members are the one who take all decisions about the treatment. So patient never does it alone. Of course, in Western world, patients would say, no, don't talk to my wife, don't ask anybody, or don't talk to my family. But here we know in India, but you never know in the time to come, patients may, want to exercise this right, that don't reveal my information with my family member without my permission. So one, asking, is there anybody outside whom you would like to engage in the conversation? One. Second, also asking that I need to discuss about your diagnosis and treatment. Do you want them to know about it? And then, and we all know, if you speak directly to the patient, it might come as a shock, and somebody might faint or somebody might pass out. So you really have to be careful before you break the news. So I think that one point Dr. Farha was mentioning, that it's always good to ask if is there anybody outside, and do you want that person to be called in? I think that's one good point. Anything else that you think that you would like to do differently?
Ma'am, he was, questioning a lot. He was regarding the treatment. I could have been a little more forthright, that this surgery you will recover in so much time, and it's not, nowadays it is done through endoscopically. So little more in detail.
But that's okay. Maybe that you would have staged it, because you need to first of all talk about little bit about diagnosis and the treatment. Then of course detailed discussion can be done in the that can be built on the consecutive meetings. That's all right. I mean, maybe in the first go you would not like to share everything. First it is to announce the diagnosis and then seek the reaction that comes from them.
And ma'am, I felt that, when Dr. Huck asked about the finances, I should have broached it also. This is a very important thing for the patient.
I'm going to talk about this part in a minute, but before that, I want to listen from the anything, Dr. Huck, you think Dr. Ravi could have done to make you, I mean, to make this whole conversation more effective, that you think? I mean, this is just from your side as a feedback to him, so that in future sessions he can remember this. Please unmute your device, Dr. Huck. Yeah.
So if I relate Dr. Ravi with the real-time scenario that we are facing in the lab, in the hospitals, is that it is not wise to disclose the condition like these directly to the patients when there is no family member or friends is there. It is very difficult.
Yeah.
Because what we have experienced that patients there is cried out, something like this.
Absolutely.
So it should not be there, number one.
Absolutely.
Number two, the patient always want to ask if the report is correct or not.
Yeah.
Always because we are facing this, are you sure?
Sure.
Can you check it with other doctors?
Yeah.
Can you refer me to other doctors? Do you feel that you should refer me to some senior doctor or something?
I agree. I think both the points.
And regarding the finance things, basically patients are very much concerned about that part.
Yeah.
That's how expensive it is. Should I borrow money? Something like that. But I think when we're handling the patients, we should.
Sorry, we lost your voice. Yeah.
Things, all these points also.
Sorry, we lost your voice in between.
Dr. Ravi is good, doctor.
Dr. Huck, once again, we lost few words. Can you repeat them? When he was talking about the finance part, what is your feeling? I think there's some network issue. I think
that is difficult.
Dr. Huck, we lost your voice once again. I'm sorry. I think we'll give you two minutes time to you get back your network, and then Dr. Kapoor, you want to say something? Yes, please go ahead.
I really want to say that he has done a good job, wonderful job explaining the clinical part of it.
Yeah.
Although expenses part of it, but let me come to the point. I still think a lot of counseling is totally focused on the technical part, the clinical part. But particularly for me, counseling is also totally related to your emotional issues of the patient, which is concerned. Like if I would have started with this case, I would have started like this. Do you remember for what conditions you have come to me? Like I did in my role play. आप ये complaints मेरे पास में लेके आए थे. Do you know that कि ये complaint क्या आप बताएंगे आपको क्या क्या तकलीफ थी? Complaints which I remember as this. And how are you feeling now? So going to the past history again, not straight away giving the diagnosis. और आपको क्या लगता है? Asking them कि how are you feeling now? What are the all possibilities which are there in your mind? क्या हो सकता है? And then slowly building up the case to give up the diagnosis, which is so serious a diagnosis.
Yeah.
I was telling you in my role, when I was doing role plays, that when we give the diagnosis of even HIV positive or mother being told that your child is suffering from leukemia, they go into immediate shock stage. The first stage is shock, and then they go into stage of denial. नहीं हो सकता है डॉक्टर साहब बिल्कुल denial stage. And sometimes they go into stage of aggression, violence. Then slowly acceptance dawns upon them. So we really have to appreciate the part of it that एक लैंग्वेज में जरूर बोलता था कहने के लिए हाँ मैं समझ पा रहा हूँ आपकी इमोशंस को. टेल मी इफ आई एम रॉन्ग कि आपको ये सुन के शायद बहुत बुरा लगा है. ये लाइन मैं जरूर सिखाता था लोगों को. ये लाइन जरूर बोलिए कीजिए क्या मैं आपकी इमोशंस जो भी इमोशन उसकी है सैड फील कर रहे हैं या लग रहा है कि ठीक नहीं है क्या मैं ठीक समझ पा रहा हूँ आपकी इमोशंस को. मैं गलत हो सकता हूँ but correct me if I am right, if I am wrong. If these are your emotions and these are normal, normalizing the emotions, justifying the emotions, that should have been done far more. And then coming to the clinical point, when the patient accepts, then going to the prognosis part and treatment part of it.
Yeah.
First part is the patient diagnosis. That should have been focused far more.
So, Dr. Kapoor, I think I will be covering all that when we will talk about the protocol of how do you break the bad news. In a 2 minutes time. So, if I may ask all others if they have any point that you would like to recommend to Dr. Ravi, which he could include in his future interactions with the patient. Maybe, but please keep it very short because I want you to give, in case if you have any input, to give to Dr. Ravi. Although
Yes.
we all have agreed that it was an excellent piece of role play and he did it in a very effective manner and in a very mature manner. Anything that you would like to recommend, Dr. Nair or Dr. Farha, anything that you think would have added to what he has already done so well?
None, ma'am. At least as far as I'm concerned, Dr. Ravi has been absolutely point on target, ma'am.
Absolutely, absolutely.
My only thing was that he took a wrong specialty of ophthalmology. He should have been an oncologist, ma'am. I wish we had oncologists like him. I'm telling, ma'am, as a medical admin, I'm telling you this because many a times we doctors, because ma'am, like we have audience from all the Asian countries. I think that is common, which is line is that we all are emotional.
Yeah.
Be it an Indian, be it a Bangladeshi or a Pakistani or an Afghani. We
Yeah.
are all family emotional people.
Yeah.
So that is there. I wish, ma'am, Dr. Ravi was an oncologist. I sure. I know he is doing very well as an ophthalmologist.
Yeah, even in his specialty, there may be situations when he has to talk about these things. I completely agree. So, Dr. Ravi, I think it was an excellent, presentation by you, excellent role play by you. Keeping in mind that you haven't had any formal training in breaking bad news, but I think based on the experience you have, the kind of cases you have held, I think it was an excellent piece of demonstration. We all got a chance to learn from, especially the tone of voice was excellent. The way you connected with them was excellent. You were really partnering with the patient, and I mean, you had all the desire to express your, being with the patient, for the patient. That was clearly visible in your communication. So what Dr. Kapoor was saying about talking about the emotional part, Dr. Kapoor, I may say here, see what we read theoretically for the Western patient clientele. There, the delivery system is very different than what we have in India. Patients in the Western world are far more informed, far more vocal also. And they also come out with what they want and what they don't like. In our country, we all understand. Country means Asian countries, like Dr. Nair said, the Asian countries. Our patients are still, mentally at a stage where they don't like to question a lot or they don't expect a lot. But yes, I think I agree with Dr. Kapoor. Dr. Kapoor, hold on. I'm understanding your point of view. Let me complete. Allow me to complete. So I understand what Dr. Kapoor is saying. Because we have never allowed them to talk, we have never addressed it. So that area remains like a closed chamber and it is never opened up. I agree with Dr. Kapoor that it's time that we start exploring that part. Maybe the shift will happen slowly. Like Dr. Nair is saying, Dr. Ravi did a good job because he addressed those things what our regular doctors are not doing. So your concern about not addressing the emotional part is absolutely justified. So here I would like to give couple of things that can help all of us to do the same thing more effectively. One thing that I will do, to start with, we have to cut down our talking. If you observe, in the initial couple of minutes you were doing most of the talking. You were right, because you had all the information. You wanted to tell about diagnosis, you wanted to tell about treatment, you wanted to tell that prognosis is very good, nothing to worry, you wanted to assure the patient. But maybe patient's concerns are very different. So it's something like you come home and you are hungry, but everybody is saying chai pi lo, pani pi lo, coffee pi lo, juice pi lo, and you are saying I haven't had food for the last 10 hours and I'm just dying for food. Give me something to eat. It's something like this. So now what we are saying, we have to understand what our patient wants to know. So much before we start talking, first I think like Dr. Farhan said, that ask, is there anybody with you? Do you want to engage them? And once they are there, Then you ask, I'm going to talk to you about your diagnosis and treatment. What do you want to know about your disease? You will have a patient who will say, Doctor साहब मुझे कुछ नहीं समझना, आप ये बताइए इलाज क्या है. And there will be patient, Doctor साहब मुझे तो मैं तो 10 जगह धक्के खाकर आया हूँ, and I want to understand मेरी तकलीफ क्या है, मेरी बीमारी तो बताइए मुझे. इलाज की बात तो बाद में करेंगे. I want to understand what it is. So every patient's information need will be different. If you will find out, then you will be spot on, because you will know this is what my patient wants to know. That is one thing. And second thing is, you were answering almost all the questions that if the patient had asked, he would have been happier. It should always be a dialogue. Somehow we are conditioned to monologue because we are in habit of doing a monologue with the patient. We assume that the patient is there just to listen. I have seen doctors saying this, पहले मुझे पूरी बात बोल लेने दीजिए, मेरी बात खत्म हो जाए फिर सवाल करिए, अभी चुप हो जाइए, मुझे बीच में मत रोकिए. I have seen doctors doing like this. From their point of view, they feel that let me first give you all the information and then you ask questions, I will answer. But if you will have a dialogue, that will help you winning your patient's confidence. आपने देखा जब डॉक्टर हक ने क्वेश्चन करना शुरू करा, then slowly there was a change in his way of interacting with you.
Yes.
Initially, he was just sitting like this and listening to you. You never knew whether he's shocked, whether he's upset, is he going to faint, is he going to cry? We didn't know. So that means right from the beginning, we have to have a dialogue with the patient. This is one point I want to highlight, because we are all in habit of doing a lot of talking and less listening. Allow the other person to speak. That is one. Second thing is, when it comes to assurance, even if this surgery is 100% safe and we know there is 100% recovery, it's an early stage, please, please, please do not over assure. Be very cautious with assurance, because it's not just the surgical outcome. It could be anesthesia, it could be infection, it could be comorbidities, it could be any on the table complication or error. I remember a case, this lady had to undergo cholecystectomy, 35 years old lady. She had to undergo cholecystectomy. She was admitted one day in advance. She had to go for the surgery. The doctor came in, chalo surgery ke liye. She said, Doctor, mera bachcha ghar se la rahe hai mujhe milwane ke liye. Young baby. She said, I want to meet my child before I go for cholecystectomy. The surgeon, in a very, jovial way, he said, it's just small surgery. By the time your child will come, you will already be out of the OT. You can play with your child. The lady went for surgery. Unfortunately, there was some complication on the table. She went into coma and she passed away after a few days. Now, how will you justify what you said? Please do not over assure. See whatever best can be done will be done. We have had cases where we had wonderful recovery. But again, always promise less, deliver more. Your patient will be happy. But if you promise a lot, please remember, patients are also going through selective listening, selective forgetting, selective attention. So later on, आपने कहा था 100% गारंटी है, आपने कहा था 100% केसेस ठीक हो जाते हैं, आपने मुझे ये कहा था. You never know. Even one case out of 100, who knows which that one case will be. So no, whatever we will do will be as per the protocol. That I can assure you. I will, if you want, I can send your, biopsy report, biopsy slide to another center if you want that to be done. I'm okay with it. Although I've got it assured, but for your satisfaction, I'm ready to send your slides for re-evaluation. But if you're over-explaining, over-assuring, it will go. Again, about insurance, you said everything is covered. You don't know. A lot of consumables are not covered. Then they'll come. क्या छोड़ डॉक्टर साहब आपने तो कहा था कि सब कुछ covered है मेरा insurance.
Right.
So more than, because we are not insurance people, I would rather say I think it is covered in your this thing, but it will be good if you speak directly to your, TPA, whoever is handling your insurance case. But I'm glad that you are insured. At least part of your treatment will be looked after. So you are giving a very, balanced kind of then again, full recovery. We don't want to give this as a, generalized statement. We don't know. Yes, results are usually very good. They're very satisfying. So one acronym that I can share with you, you can note down, that is IIC-EE. If you want to understand how is this patient thinking or feeling about the disease, it will help you. IIC-EE. The first I is what is patient's idea of the illness. So like before you say it's cancer, if you ask, आपको क्या लग रहा है कि ये टेस्ट जो हमने कराया है क्यों कराया है, आपको क्या लग रहा है, बाकी डॉक्टर्स ने आपको क्या बोला है, maybe the case is referred to you by another doctor and the patient already knows. Maybe the patient has been referred by a small time practitioner who has just given a element of doubt कि ऐसा लग रहा है कि there's a possibility of cancer. So first I is what is patient's idea of the illness. Second I is patient's impact of the illness on the patient. Impact of the illness on the patient. A patient with fractured foot and a rickshaw puller will be impacted differently from the patient who is a homemaker. Of course, the life will definitely be affected in both the cases, but there it is livelihood. Here it is just day-to-day functioning. So impact of the illness. C is what are patient's concerns. This is very important. आपको बीमारी को लेकर क्या कंसर्न है या इलाज को लेकर क्या कंसर्न है, आउटकम को लेकर क्या कंसर्न है. So when you ask concern, they may have concern about duration of stay or treatment cost or follow up. Maybe they are not from the same city. डॉक्टर साहब दोबारा अगर आप बुलाएंगे तो मैं कैसे आऊंगा, I am staying in another city. It could be anything. It could be कि मेरे पास कोई रहने वाला नहीं है, अगर आप एडमिट करने के लिए कह रहे हैं मैं तो किसी फ्रेंड के घर मिलने के लिए आया था. It could be anything. So concern. And the last 3 E are, first E is emotions. Emotions of the patient. Like Dr. Kapoor was saying, explore patient's emotion. आप बहुत upset लग रहे हैं, आप बहुत उदास लग रहे हैं, आप naturally anybody will be upset. So emotion. Second is patient's past experience or experience with the illness, with the hospital, with किसी की अगर डेथ हुई है उनकी नॉलेज में बिकॉज ऑफ कैंसर, वो बिनाइन भी होगा तो उनको लगेगा कि मेरा ये कैंसर जो है मैलिग्नेंट है. सो पास्ट एक्सपीरियंस. एंड द थर्ड ई वेरी इंपॉर्टेंट, व्हाट इज देयर एक्सपेक्टेशंस. So you have to check this and then accordingly handle that. IIC-EE. So I'm going to share the screen with you and show the presentation very quickly. Most of the points we have discussed, but then it will give you a structure of how do you go about delivering a bad news. So it will be, kind of summary of what we have discussed till now. Any questions from any side, from anybody? Okay, so I'll quickly move to the presentation. So I'm sure as clinician, you must have experienced how difficult it is, especially those who are, seasoned, they must have been comfortable doing it. But for any young budding doctor, it's not easy. It's very challenging. And at times we fail because we are not good at handling emotions. Patient's perspective. We like Dr. Haq shared his real life experience with us that years ago when he was told that this is what is your diagnosis and later on it was found to be wrong. I'm sure patients are affected, much more than we are affected. So in this study, 79% of the patients and 68% of the families said bad news encounter was suboptimal because a lot of them felt the physician was too blunt. Like Dr. Nair was saying that people are not very compassionate when they are delivering the bad news, or the place or the time was inappropriate. Sometimes we do it in the OPD, sometimes we do it the bedside, sometimes we do outside in corridor, or the timing also could be wrong, not appropriate for the patient or for the situation. Patients also got the sense that there is no hope. So sometimes when we are too blunt in talking about the diagnosis, we forget to give a very balanced kind of information where the patient goes back, okay, we will do what best can be done. We should do whatever best can be done to save the patient. And of course, they wanted the physicians to balance between sensitivity and honesty. So we try to be honest. We are scared if we don't tell the truth tomorrow, the patient might catch hold of us saying that you did not tell me clearly. But at the same time, we need to be sensitive when we are breaking such a news. So the gap between what the patients want and what they receive says 57% of the patients wanted to discuss life expectancy. How much life do I have? How will this impact my lifestyle or quality of life? But only 27% of the physician did the discussion about the life expectancy. 63% of the patient wanted to discuss about the effect of cancer on other aspects of life. But only 35% of the doctors actually did it. Rest of them were too focused on the clinical explanation and the treatment part. So breaking up bad news is one of the trickiest, communication, and probably the one where actually, you can expect a lot of aggressive reactions coming from the patient side, especially if they are not prepared or they have no idea about the diagnosis. Younger doctors experience more challenges because they find it difficult to handle their own emotions and handle patients and families' emotions. So usually it's more like a reactionary kind of aggression that you would see. Breaking up bad news actually requires advanced level of communication skills. A lot of patience, a lot of demeanor, a lot of compassion, a lot of empathy, which comes with a lot of experience. You're handling your own emotions, handling patients' emotions, and you have to be really good at words. The same thing can be said in so many different ways. And we saw Dr. Ravi using a lot of good words when the patient asked 100% guarantee. Then he said, that he handled it very well. And even when the patient asked about one more thing, Dr. Ravi handled it very well. Second opinion, he handled very well, that I'm okay with the idea of, second opinion. Normally we get upset about it, but then he handled it very well. So one really needs to be good at words and handling emotions of the patient and patient party. And also there is emotional, overwhelming inside you because you are also affected in this situation. Patient might think it's failure from your side. You did not do things on time. You did not take my problem seriously. You did not get the investigations on time. So all those, thought processes are going inside, and that is very overwhelming for anybody. So one word of advice that I always, find very useful is please build good rapport with every patient, because you never know which case might turn into an emergency and have an unanticipated outcome. If you have good rapport, if you have this image on the patient's mind that you are a good doctor, responsible doctor, trust me that they are less likely to blame you. They're less likely to fight with you. They're less likely to become aggressive with you. So creating familiarity actually can reduce the risk of aggressive reaction. Studies have shown that patients and families are less likely to be aggressive with the doctor that they're familiar with. So creating familiarity goes in our favor. So when I say creating familiarity, I'm not asking you to be friends with the patient or patient party, but addressing their queries responsibly, answering their questions, regularly updating them, especially when you know the patient is critical. Anytime the patient might die or may turn into a serious condition. If you're regularly updating them, they get prepared for the eventuality. And then, of course, while decision making, involve them, engage them, ask them, are they okay with this? For example, if you want to put the patient on ventilator, give your opinion that I think at this stage he requires ventilator support because his lungs are not functioning effectively. But I would ask you to discuss with your family and take a decision. So that way they feel that they have been empowered with the autonomy to decide what they want to do. rather than being forced about. So somewhere, Dr. Ravi, when you were explaining that let's start the treatment quickly, it can come about as you are in a hurry. Although I understand your concern was that treatment should begin as early as possible so that the patient recovers, but it's a double-edged sword. So we have to let them decide, saying that yes, it's very important to start the treatment as early as possible. Any delay can be fatal and it can lead to spread of disease. But then leaving the ball in their court is very important. I think through and through, transparency and honesty will play a very big role, even if there is an error from our side. They will still believe that you haven't done it deliberately. Please remember, when the patient is in critical condition or has a serious diagnosis, the family is looming under the greatest fear of life. And what is that? Fear of death. Fear of death. And studies have shown we look after the patient very well, but when it comes to considering family as the beneficiary of our care, we do not pay much attention to that. Whereas if you see, patient is far more comfortable than the family. Patient has a bed, patient is getting medical attention, nursing attention, medicines, food, everything on bed. It is the family who is either sitting in the corridor or in the lobby or running around and arranging funds and arranging medicine and arranging all sorts of support, whatever they can do. And over and above that, there's a family at the back home who needs attention. It could be an elderly parents, or it could be somebody who is sick, or young kids, probably who have exam, or they need to be attended 24/7. So though all those challenges are with the patient's family, so we have to consider the family's emotions and their concerns equally as we attend to the patient and their patient. Even the residents, nurses, and paramedical staff, they play a very big role. I always say, when the patient is in critical condition and is in ICU, please be more understanding and considerate. Be accommodative to the family's need. See, especially if the patient is in critical condition and we know the prognosis is poor, and if you insist on the rules of the hospital, no, you can only meet morning, evening. If a relative has come from a very far off place to meet the patient and we say no, you cannot visit without visiting us, maybe by the next visiting hours the patient is already gone. On the contrary, if the staff and the residents and the support staff are sensitive to the fact that the patient is in critical condition, if not with everybody, but at least with the close relatives, we can allow them to visit little more frequently, with the instruction that please don't touch anything, please don't disturb the patient. There are other patients, don't be inside for very long. Then go and just have a look and come back. Trust me, they'll thank you all their life, because you have been able to understand their state of mind. So breaking of bad news should be done by the senior most person present in the system at that moment. Although in a lot of places I've seen residents doing it because they are the only ones who are handling the situation. But it should always be done by the senior most person. Others can be around to observe and learn from how it is being done. So I'm going to share the breaking of bad news protocol. There are many protocols available, but I find this very simple and easy to grasp and apply also. This is called concept of 4 P's. The first P is about preparation, that is preparation of the physician, place, and patient. Second P is about performance. How do you go about doing it? Third P is about palliating. And fourth is how do you go about planning the future. When we talk about the first P, that is preparation of the physician, it's very important to know and confirm the facts. Like in some cases, we have seen that in hurry, we go and announce the diagnosis. If I tell you about my own father-in-law's case, day before yesterday, I was told that he has developed aspirational pneumonia because they got the X-ray done and one lung is completely, shaken. So they said it is aspirational pneumonia because you tried to feed orally. Okay, our mistake. Next day they say, no, it doesn't look like aspirational pneumonia. It looks like there's a block, there's some lump in the bronchi, so it's not able to, the air is not passing to that. Okay. Third, now they are saying they've done the CT. Yesterday they did the CT scan, and now they are saying that there is pleural effusion and we need to do the tapping. In 3 days, we have changed 3 diagnoses. And on the day one, when they said it is aspirational pneumonia, they said one lung is completely gone and the other lung is also affected, and there's only 5% chance of survival. Now imagine how much in hurry they have gone about breaking the news.
Mhm.
So one should be 100% sure before you go and announce any diagnosis. There is nothing wrong even if you check, recheck, because you are going to tell something that can do the damage immediately. Before you start speaking, it's important to make connection with the patient. Like Dr. Kapoor said, ask the patient, do you remember what your previous doctor had said? Do you remember what symptoms you had? So what you are trying to do, you are trying to you know start from the beginning so that the patient knows that this is what I already had, and based on this is the diagnosis. You could also ask, how are you feeling today? How's your fever? Is there some change in the appetite? So that's a way you kind of start with some small talk before you go ahead with the big talk. Then, of course, when you're going to break the bad news, please be mentally ready to spend some time. A lot of time we are in a hurry to do this. We assume that it will take just 2 minutes and we move on. Actually, it may not do that. And if you show hurry, and if you say that, oh, there are patients waiting outside, oh, I have to go somewhere, and you look at watch 3-4 times while talking to them, patient and the family feel that you are in hurry and you are not serious about their problem. So whenever you're going to break this kind of a news, please be mentally ready to spend some time with them. Especially they'll have a lot of questions. They may ask you to explain what are the options for treatment. Can we try allopathy? Can we try homeopathy? Can we try Ayurveda? And what not? So be mentally ready to spend some time and answer their questions, and allow them to clarify whatever they want to do. So in between, having interruptions like phone call visitors is not a good idea. Please put everything on hold. I have again written, please do not delegate. The doctor who has been treating the patient should be the one who announces. I've seen this again personally. This young boy who got appendectomy done by a very senior surgeon. Unfortunately, he developed fistula, and this I mean, he was very surprised. What is this and why this has happened? But this news was not shared with him by this surgeon who had operated. It was some resident who came and told him, "Okay, there's a fistula and this will take some time to, correct that." He was shocked that why did this surgeon? And before this surgery, he was at another hospital and he contacted the patient care coordinator for admission. He constantly received call from this patient care coordinator. "Aap yahan aa jaiye, there's a bed available. We'll get your surgery done immediately. As soon as you come in, then this doctor will operate." But after the surgery, there's nobody listening and nobody ready to. So patients really can sense that. See, when we were a potential client, they were very nice and kind and accessible. And now they have done with our surgery, they have done, see, now they are not ready to. So all these things do affect patient psyche. So please do not delegate to anybody. If you are the treating doctor, make sure that you do the breaking of bad news, because by now you have developed rapport with the patient. Even the patient is confident that you know everything about the patient's condition. But place where we set up the breaking of bad news, I know now we have counseling rooms in almost all, at least private hospitals and corporate hospitals. Government hospitals are still to, have a counseling room. Unfortunately, the government hospital is either done in the corridor or bedside or in the OPD, which is very, very unsafe because others are overhearing, and there's a risk of people unnecessarily interfering in the situation or also instigating the patient party. So when we talk about the place, I think it's very important to sit down at a separate place. Ensure their privacy. Also ask, whom do you want to engage in the conversation? Very clearly, explicitly, you can ask, do you want your like for example, Dr. Huck said that don't share this with my wife. Of course, this has to be dealt with, and we'll talk about it when they say that don't share with my wife. And suppose if it was an HIV case and the patient says, don't tell my wife, we know that the patient's family can be affected, especially the wife can get infected. So there you have full right to, not honor patients' this thing. But before that, you have to explain to the patient why it is important to inform the family members. But in general, I think ensuring their privacy, having a separate place where you can sit and talk comfortably is a better idea. Of course, involving somebody like a social worker or a senior nurse or a psychologist. Now I see a lot of hospitals are also having psychologists on board to handle such situations, and also be in touch with the patient to look after the psychological and emotional needs of the patient. So it's a good idea to have a psychologist or a social worker or a senior nurse. Of course, a glass of water, facial tissues, they are helpful in communicating that you understand that people will get overwhelmed, and it's perfectly all right when you are upset with this. Before you start speaking, it's important to, you know, uh, assess from where do I have to start. Maybe this is a case who has already been identified or diagnosed with the cancer. So probably you just have to say, I think the reports brought by you and the recent tests that we have done, they are more or less, same. So there is not much difference. But asking the patient, what do you know about your condition? What has your referring doctor told you? What is your understanding for the reason why we did this test? Will also give you an idea how much patient knows and what is the starting point that you should be. As I said earlier also, please check patient's information need. Somebody might want to know everything about, somebody would not be ready to receive any information, somebody would like to engage family members in discussion. So it's good to ask whom they want to engage. This study says, 2,331 patients were interviewed and 98% of them wanted to know if the illness was cancer. Although I know a lot of time I see patients, family members coming and saying, please don't tell my mother that she has cancer, or please don't tell my father that she has cancer or he has cancer. I've seen actually patients dying without knowing that they have cancer. Again, it's important to check what does patient want, but mostly they want to know, and it's important to let them know. We'll talk about it in one of the next. So 87% of the patients preferred as much information as possible. And that is why when they don't get all information from us, they will go hunting for information on Google. And we don't like that. When they come up with questions based on the information they have read on Google, we feel bad about it. But because there is no other source, so therefore they go to Google uncle and ask their questions and get some answers from them. You will also see that there is a possibility of illness denial, wishful thinking, unrealistic expectation. So what is patient's perception about the illness? So that double IC triple E that I said, this will give you an idea about what is patient's understanding of their illness. If you identify illness denial, wishful thinking, please address them appropriately at the same time. Any misinformation has to be corrected then and there. Otherwise, later on, you can be blamed for negligence and failure to do the right treatment. In case if you identify anything like this, please tailor the bad news, and you can stagger it. While breaking the bad news, please be sensitive but straightforward. Don't try to minimize the severity, as any effort to soften the blow can lead to weakness and confusion. Selective listening, selective attention, selective, forgetting, they all come in the way, and they'll say, Doctor Sahab, aapne to ye kaha tha, aapne to ye kaha tha. Then that can, create confusion. So while you are explaining the about disease and the treatment plan and prognosis, it's very important to use simple language, as simple as possible, because they will not understand sometimes, but they may hesitate asking you to explain further. So it's a good idea to use simple language, avoid all technical jargon. Even if required, use audio visual aids. You can show, draw and explain. If you want to talk about obstruction, explain how it is obstructing, and how, if you want to show about the change in the size, draw on a piece of paper, show them the change in this size. So all that will help them conceptualizing what you are trying to explain them. Because, for example, even this case of pancreatic cancer, if you were able to draw pancreas and show them the size of the cancer or area that's affected, that will give them an idea. Okay, this is an localized, and the recovery is better, or the treatment will be better. As I said earlier, also, please avoid single steady monologue. It's always a good idea to let them speak, because when they will speak, you will get to read their mind. You will get an idea what they are thinking. You will get an idea what are their concerns. You will get an idea whether they're agreeing with you. You will get an idea whether they are understanding what you are saying. So it's always a good idea to open a dialogue with them rather than continuously speaking and saying whatever you want to say. Pause frequently so that they get a chance to assimilate what you're saying, or in case if they want to ask you something, they are able to ask you, because if you're continuously speaking, even if they have a question, they will hesitate interrupting you, and by the time you will finish your monologue, they will forget about the question. So that means there are questions that are not attended. So it's always a good idea to give chunk and check. Give small information and check. Are you understanding? Is it making sense? Do you need some more explanation? Is it making in between using silence and body language, appropriate body language? This also, facilitates discussion. So if your body language shows authoritativeness, intimidating, rude, or being one up, they will not open up. So when you lean forward, try to connect with them, make eye contact, pause in between, use silence. They feel encouraged to ask or speak in between. And then of course, don't forget to check for understanding. A lot of time you will spend good 10-15 minutes explaining them, and their last question will be, डॉक्टर साहब बच तो जाएंगे ना, ठीक तो हो जाएंगे ना, नजर तो वापस आ जाएगी ना, चल तो पाएंगे ना, देखने में दिक्कत तो नहीं आएगी ना. That means they have not understood what you have said. So therefore, keep checking in between rather than wait at the end patient asking you something. This we have discussed earlier also, so I'll not spend much time on it. We all know that 93% of the communication is non-verbal. So make sure that your tone of voice and your body language communicates, compassion, care, concern, and desire to support the patient. Whenever you are entering to break the bad news, it's a good idea to greet them or ask them, Namaste Baba ji, kaise hai? Kaisa feel kar rahe hain? I heard Dr. Ravi saying, hello Mr. Hawk, how are you? Good morning, good evening. So he did greet. Establishing eye contact is very important at this point. By the way, if you don't make eye contact, how can this be misread? When you don't establish eye contact,
as some guilt or wrong treatment on your part.
Absolutely. So it might be read as some failure on our part. So at that point, establishing eye contact is very important. That will instill confidence in the patient and also showcase that you are not guilty of any failure. Your posture again has to be open, because if you are sitting with hands closed or if you are rocking in the chair, all that is not really desirable. Leaning forward is a good idea, using the appropriate tone, allowing the patient to express, listening attentively. So when they speak, we have to simultaneously listen attentively and nod when it is appropriate. There will be emotional reactions. The patient might break down, patient will start crying. So we can't say इसमें रोने वाली कोई बात नहीं है, तो छोटी सी बात है. टीबी का तो पूरा इलाज आजकल अवेलेबल है. आप देखो, आप गूगल सर्च करके देखो टीबी की कितना इलाज अवेलेबल है. If they are feeling overwhelmed, they are feeling overwhelmed. They don't want their emotions to be refuted or invalidated. So we have to accept emotional reaction, and we don't have to react to everything. A lot of times just keeping quiet and allowing them to get back their composure is also okay to deal with that situation. So comforting the patient or the family with appropriate verbal and non-verbal gesture is helpful. For example, if you have good rapport with them, and if the patient is elderly patient, if you touch on the arm or on the shoulder or on the head, so it's like like you are comforting them or kind of communicating that I understand what you are going through. So what are the different ways to start the conversation? Can you suggest some ways? How do you start the conversation? For example, you have confirmed it's cancer. It's cancer, stage 1, 2, 3, whatever. How will you start? So Dr. Ravi, when you started, you said कि आपका जो हमने फाइन निडल एस्पिरेशन करा था, FNAC करा था, उसकी रिपोर्ट आ गई है और उसमें आपका जो है कैंसर निकला है. Am I right?
Yes, ma'am. It was, I feel we should ask how they are feeling today, little lead them into it gradually.
Yeah. And also, again, that should not sound like faking when you're asking how you're feeling today. It should not look like we are just,
No.
In a theoretical manner we are doing. So maybe we can be very specific. For example, did you sleep well? How's your pain now?
How's the pain?
Are you feeling better? Did that medicine help you in relieving the pain? So could you eat your food today? Or we change your diet? How is that diet helping you? I mean, something that is true to the situation, but that gives you little time to start. But when you're going to announce, नॉर्मली वी से आपका वो जो टेस्ट करवाया था उसकी रिपोर्ट आ गई और वो जो है वो कैंसर है और I know that's true, but these are few ways when you start something like this. I really feel bad to tell you that the report reveals something, or unfortunately I've got some bad news to tell you. I'm afraid the news is not good, or unfortunately there's no question about the test result. The report is back and it's not as we hoped, or I'm afraid I have bad news for you. What I'm saying, when you use such phrases, it kind of gives them a feeling that, okay, even you are, concerned about it. This is what patient party wants to, experience. That doctor is concerned. Although practically it is not possible for anybody to be, if you have 100 patients, you can't, be 100% with it. But it communicates that you are understanding what they are going through. So how does bad news hit the patient? Very honestly, actually, bad news result in cognitive, behavioral, and emotional deficit. So you will see they'll usually be suddenly numb, quiet, not knowing what to say or how to respond, because this comes as a shock. So you will see that they will suddenly become very silent and quiet, or might react in a different manner. See, you can't change the news, definitely. But at the same time, if you give them realistic hope, you can make things better. Or if your behavior throughout the breaking of bad news is cold, you can actually make it worse. So if we talk about the psychological responses of the patient, 54% of the patient actually responded with shock. As I said, patients normally feel, shocked. 46% of them reported fright, that they were really scared. 24% reported sadness. 40% accepted the situation. And 15% said that they were not worried. But you can see most of them would be shocked and frightened. And that's what leads to cognitive deficit. Although that is momentary, but that's how the human mind absorbs the shock. Now, the patient might respond maybe by crying or suddenly becoming silent, or they may ask you, are you sure? Or could it be a wrong report? Are you sure that this report is mine? Or they may say, don't tell my husband, don't tell my wife, don't tell my family. This is how they may respond immediately in that situation. The psychological response is called DABDA. DABDA, DABDA. It's an acronym. So D stands for denial. So usually they are in denial and shock. A is anger, unhappiness. So they may become very angry. They may become very unhappy. They may become aggressive with you. They may even become revengeful. Or they may blame you for what has happened to them. You did not look after. You did not do the test on time. You kept referring us to different people. So you delayed the treatment. You did not attend my call. So they may blame you for all those things. B is bargaining. So once they start realizing that this is a true situation and we have to face with it, so they may request you, Doctor, can we go for a second opinion? Can we take this treatment? Can we get the test done once again? Can we try once again? So bargaining is more like, they are not able to accept. So they are finding some way to trade the situation. So usually they'll say, "Kitna bhi paisa lag gaya, doctor sahab, patient bachna chahiye. I don't care for the money, but please look after my patient well. Can we take the patient to another hospital that is better equipped?" Once they get to realize that actually situation is bad and it's saddening, they will become depressed. It's more like becoming quiet and accepting the situation. Now, how do you deal with it? Denial has to be dealt with information. So when you see that they are in denial, show them the report. Tell them that this test has been, confirmed, reconfirmed, or we had sent your biopsy slides to 2, 3 different renowned setup, but all of them have confirmed that this is, cancerous. So providing information will kind of help them accept the situation. When they're angry, there's no need to react to anger in a reactive manner. Stay calm, listen to them, and be supportive. Of course, you have to look after your, safety. That has to be looked after, but there is no need to react to the anger in a reactive manner. When they are in bargaining mode, help them see the reality, empathize, and when possible, assert to help them know that if money could save, I would have asked you to do that. If going to another hospital could have helped, I would have definitely asked you to, go for to the another hospital. When you see them depressed or quiet, it's time to give them direction, to tell them what needs to be done, because they may be clueless on what next. Where do they go? Who will help them? Where should they get the test done? Where should they get the treatment done? And once you have explained them about that and you see them accepting, that is where you have to encourage them that I really, I really appreciate your courage. I really appreciate your confidence. I really appreciate your desire to, fight with the disease. So that's like encouraging them to take this stride and, move on with that. So at this moment, empathy will play a very big role where you can actually, which we saw Dr. Ravi was using a lot of empathy in his uh, conversation with the patient. At number of places he said, "We will do our best. We are there. We understand." So basically, this is what probably patient is looking for: somebody who shows that I will do my best to help you and provide you. Now there are different ways that you can, express empathy. For example, when you say, "I can see how upsetting this is for you, and I know you were not expecting this." So, like Dr. Kapoor was saying, I also ask and tell, "Please correct me if I'm wrong. I think you are really affected by this." So what you're trying to say, you are trying to validate, you're trying to acknowledge and validate. And I know anybody in your place would be, disturbed or upset. This would have been very difficult for me also. For anybody, it would be very difficult. So different ways to indicate kind of, that yes, it's a tough situation and you are really holding a very brave front. Okay. So if we look at it from the clinician's point of view, I think it's not easy for anybody, at least when you start your career. So Dr. Ravi, how do you feel if you have to break the bad news now? I mean, having had done your practice for so long, if you have to break bad news, how do you feel now?
Ma'am, I still don't feel very good. I think when we started with your workshop and you brought this concept of empathy, I mean, that how important it is. We do empathize, but I think I was going the other extreme that sometimes, you really feel too much and it affects you to the, sometimes you have a bad report or a bad, surgery doesn't go as expected. But really, I mean, this has made a lot of difference to me. And now I'm able to, talk to them more as a friend or an elder brother or, and be there. So it's very helpful now.
Thanks.
Yeah.
Thank you. Thank you. Dr. Farha, if I may ask you, how do you find, what do you experience when you have to go and break the bad news? In case if you have had the chance to do it. I'm sure you must be doing it once in a while.
Yes, ma'am. I also feel very bad I take preparation. At first, I actually take preparation and then I speak to patient. I try to empathize them, but first I prepare myself for that. That's how I do it.
Absolutely, absolutely. So I think nobody's, how much ever seasoned you are, it's not a very pleasant interaction. It's not a very pleasant communication. So anybody would have difficulty talking about bad news with the patient, especially when patients have very high expectations from you, because higher the faith, higher the trust in your way of functioning, the more the discomfort, because patients' expectations are going to be affected. Then also there's a fear that you're going to destroy their hope. So once you say that it's stage 4 and there is no hope, it's like, even a lot of patients and their family members, that's what they say, that it's better if you don't tell us, at least we will continue taking treatment. We will continue coming to the hospital. We will not give up. So again, it's a double-edged sword when you tell them that you have only this much time. So in a way, you are preparing them, but at the same time, it comes as a shock to them when you tell them that your death is already kind of decided. There's also a feeling of inadequacy in the face of uncontrollable disease. So on one side, we feel very empowered and very confident and very competent, but we know there are a number of diseases where we feel so, inadequate in managing them and treating them. Like even COVID-19, that has actually shook our confidence in us. Although we have treated so many patients, but at the same time, the way every time treatment modality changed, people were really feeling very, not clear about what exactly will work in that situation. And then a lot of time we are not prepared to manage the patient's anticipated emotional reactions. I've written anticipated specifically. These emotional reactions are bound to occur. If you know this, you will not be unhappy. If you will know this, you will be ready for it. If you will know this, you will be prepared to manage it. That's what I want to emphasize on. See, that's how human mind functions. So family's reaction is not something unjustified or unfair. Put yourself in their position. Denial is very common, very common. You can't believe that this has happened with me. So if you know how to handle those emotional reactions without getting attached to the situation, without overreacting to the situation, actually you will be able to handle the situation very, effectively. And then of course, sometimes when you have painted a very optimistic picture, it becomes very embarrassing. Like the example that I gave you for that cholecystectomy patient. I mean, that surgeon had given a very, very casual kind of a thing. Oh, it's a small surgery. No procedure is simple. Even a test dose can kill the patient. We have to remember. So we cannot say that it is. I'm sure Dr. Ravi must be knowing. In Delhi, we had this tagline: "Ghar se aiye, surgery karwaiye, office jaiye." You remember this tagline in Delhi? They don't use this tagline anymore, because even if one patient loses, vision because of nucleus drop or any other complication, your tagline becomes meaningless. So it's not a good idea to give a too optimistic picture. So the best way to deal with these, situations is, please give realistic expectations. Never give, high hopes. As I said earlier, also, please promise less and deliver more. They'll be happy. Accept your professional limitations. We are not God. We are human beings. Medical science is still incomplete, and a lot of time we do not even agree for other options of treatment. We think allopathy is the only and only way of treating. Pardon me for being blunt on this. Much before allopathy, we had so many other treatment modalities available, and they were doing very well. Of course, it is technology based, advanced technology based, and it is definitely helpful in a lot of acute problems and handling, controlling chronic conditions. But for a number of diseases, we still don't have any cure, permanent cure, and we can't deny this fact. If we keep this in mind, I think we'll be far more humble when we interact with the patient. Then we have to mindfully learn to control emotional reactions. We don't have to give tit for tat. We have to understand they are suffering, they are in pain. We are in better position than them. So we have to really mindfully learn to control, emotional reactions. Keeping the family updated will help you prepare the family for the eventuality. If you tell them the prognosis is poor, the things are not going well, BP is not going up, respiration is very shallow or intermittent, whatever the condition, they would slowly get prepared. I would say allow them to see the patient. And a lot of time when they will come out of the ICU, if you look at their facial expressions and hand movement, it will be on the side of their body and it will be moving like this, which is an acknowledgement of the fact that the condition is serious and there's less chances of recovery. So keep them updated, let them see the patient so that they slowly get prepared for the eventuality. And last but not the least, document all communication. Please don't forget to document whatever you communicate or whatever communication comes from them. So once you break the bad news, usually the patients fear that I'm going to be left, I'm not going to be attending. They fear abandonment. So it's very important to establish a plan of treatment, treat their current symptoms, discuss the treatment plan, establish a time for follow-up in case if they need to come for follow-up to you, and also assure them that they are not going to be abandoned. In case you need to refer them to another setup, please arrange for appropriate referral, give contact details of the person who we are referring, make a proper summary of your understanding of the patient's condition. If possible, speak to the other doctor so that you can brief about this case, and then involve potential source of emotional and practical support like family, friends, social workers, spiritual counselors, peer people. We don't normally value them, but trust me, they will take away a lot of your burden of providing emotional support. But we need to acknowledge their contribution. Disease and death, how it impacts anybody's life can only be understood when you experience something like this. I don't wish anything of that sort for anybody, but I think that makes us more humane, more understanding. So that brings us to the end of this topic. Any questions about what we have discussed till now?
Ma'am, if I may just add in,
Sure.
when we talk about like an important aspect is of the doctor's psychology also, ma'am. Like while breaking, because like Asians or I'll say specifically Southeast Asians, because at times we become so emotionally attached to the patients.
Yeah.
Over a period of time, it is emotionally straining. It puts a lot of strain on the doctors themselves. We look after the patients, but then unfortunately there's no one to look after the doctors who are treating them. Very unfortunate part.
Absolutely. Now we are talking about that concept of second victim. We are talking of that concept of second victim, where we are talking about the healthcare providers who also equally suffer. We'll be talking about, in short, about it in disclosure of medical error. Because normally when there's an error, we shift the focus on the person who has committed the error. And that person feels, ashamed and sorry and disregarded by all of us. And we need to be sensitive to that. But of course, I completely agree with you that their mental health has to be looked after. But at the same time, I think individually we all have to take the responsibility of looking after ourselves. We have to bring in this concept of detached practice. When I say detached practice, I don't mean being cold and insensitive. I mean there has to be a clear line, that there's a line between patient and me. Empathy does not mean I engage emotionally with the patient or the family. I think these are very careful, mindful practices that we have to imbibe and practice if we want to stay detached but still caring and compassionate towards patients. Empathy is actually a very huge topic, and we normally cover it under emotional intelligence. So, but we have kept it very short in this because there are so many topics to be covered. I'm missing on a lot of topics just because we can just choose 10 topics for this program. Empathy and assertive communication, they both require detailed full session. Full session. So any questions on what we have discussed till now?
Ma'am, just one comment that I think the best thing was one of the real things, like you said, promise less and deliver more. And I see it happening amongst a lot of my junior colleagues. In a bid to attract patients, they will trivialize everything. And which I always, even a simple, say, day-to-day cataract surgery, which we do, I tell them that anything can go. After all, it is a surgery. We will, just patch it for half an hour. We will discharge you in 2 hours. But still you have to go through it, as and it's not, don't take it so lightly. We will do our best. So, and that gives us a lot of peace of mind to both,
So those 15-20 minutes spent before the surgery with the patient for informed decision making or informed consent taking, it saves you a lot of tension and unnecessary botheration that you have in your mind. Suppose if this happens, suppose if this happens, suppose if the patient family becomes aggressive or they don't take it. So it's better to spend those 15-20 minutes at peace with the and ask them, is there any more question? Do you want to ask anything? Are there any concerns that are bothering you? Spend time in and once you're honest and transparent, they are thankful to you to have come up. For example, if you know the prognosis is poor and you tell them there's no possibility, there's no, even if you go, if you want, you can go and speak to another doctor and surgeon. They'll come back to you because you are more transparent and honest in your answers.
Yes.
Absolutely. Any other question or comment or anything that you wish to say? So, Dr. Rashmi, can we do a presentation next week? Sorry, not next week. Sorry, on Thursday.
20th.
20th, yeah.
I'll give my presentation.
So Padma, of course, you had mentioned that you want to do on 20th. So
Yeah.
Rashmi was scheduled for today, but it's already 10:15. So I think it's not right to hold everybody beyond this.
Yeah, 20th, I'm not very sure, but yeah, it's very late now, 10:20 almost.
Yeah, but if I may ask, yeah, go ahead, please. Somebody want to say something? Go ahead.
Ma'am, I have only one question.
Yeah.
As these are all people from healthcare background, they can easily handle a situation, or they can easily handle the crowd. But I'm not from healthcare industry. While I'm delivering, you are each and every point on the PPT you are explaining. So for me, I don't have any experience in healthcare industry. How can I satisfy my trainees?
But I think we will discuss this. You can call me.
Okay, ma'am.
Speak to me, and I will try to help you how you can,
Okay, ma'am. Okay.
But I think right now it's not.
Okay.
Yeah.
Ma'am, just a suggestion.
Yeah.
If it is, on Thursday, then can I have it at the beginning of the session, please?
Okay. First of all, let's ask, is everybody okay with Thursday? I think Janvi had an issue on Thursday. Janvi, are you attending on Thursday or no?
Yes, ma'am, I'm there.
You are
Thursday, I won't be attending. I'm there for today's session.
Oh, you will not be attending.
Thursday.
If it is next week, it is fine with me.
What do others say? I don't want. Yeah, Rehan, you want to say something? Yeah. Sorry.
Next week, madam.
So you would prefer next week?
Yes.
27th?
Fine.
27th?
Yes.
Because Tuesday is Diwali, so it's not possible.
Tuesday, Wednesday also. Bhai Dooj is on Wednesday. So Thursday is fine, 27.
So is everybody okay with Thursday? Dr. Kapoor has said something.
That is, it is difficult for him.
Yeah. Then I think if everybody is okay, I have no problem. Purpose is that everybody should benefit from it. So let's meet next Thursday, and we will have 2 presentations, one by Rashmi ji and second by Padma.
Okay.
And
Thank you. Thank you, ma'am.
Padma,
Thank
you call and speak to me about your concern.
Thank you.
Okay, ma'am.
Thank you.
Thank you very much, everyone,
Thank you.
for
Thank you.
patiently being with me till this time. And I'll share the feedback form link. I request you to give your feedback on this session.
Sure, ma'am.
Thank you so much.
Thank you.
Good night.
Thank you. Thank you.